my name's Cary Adams, and I'm the CEO of the UICC. And it's my great pleasure to have a conversation today with Julie Gralow, who's the Chief Medical Officer of Asco and been a good friend to UICC for many years, working on all sorts of things. But Julie, nice to meet you. Thank you very much for talking to us. I think quite a few people want to know, what does a CMO of Asco actually do, and how long have you been doing it now?
That's a great question. And we've only had a chief medical officer, one prior. So we've only had about 8 years of a chief medical officer now. The chief medical officer is the medical voice, essentially, of Asco. Our CEO is more the business end of things, and the chief medical officer really oversees the medical piece of things. And we're a professional society of oncology professionals. Specifically, I oversee Centra, our Center for Research and Analytics, where we do some pragmatic trials, registries, our COVID-19 registry. I oversee policy and advocacy, care delivery, and importantly, especially for UICC, our International Affairs Group, which is a real passion of mine.
Well, you say it's a passion for you. I think that's how we first met. You've certainly been someone who's committed to at least consider and address and support individuals and organizations in lower middle income countries, particularly on breast cancer. And perhaps I'll talk about that for a moment. Now, we're in October, big month for UICC and the cancer community. It's Pink October, so breast cancer awareness. And it's also the World Cancer Leaders Summit on the subject of innovation addressing inequity. So if you don't mind, I'd like to explore those a bit with you, because I know breast cancer, particularly for you, being an expert in the field, acknowledged expert, but also a passionate advocate. There's been a lot that you've done in that, which has been looking at the inequities around the world and forming new groups like We Can, which was the advocacy group for patients in low middle income countries to get together and argue for better treatment and care. So what's your involvement at the moment, given your new role? I mean, are you still passionate, involved in that? What are you doing?
Absolutely. And that was one of the things that attracted me to Asco, was our big commitment to equity, every patient, every day, everywhere. And that everywhere meant not just in the US, which has been a focus of ours, but actually everywhere in the world. So it was great to be able to have a voice now where my day job was to promote equity everywhere. I'm very passionate about bringing the patient's voice to the table. In the past, they have been left out of some very important decision-making, but educating, networking, bringing together, just facilitating the ability of patients to learn, to be at the table, has really been impressive in terms of some of the accomplishments that have happened, particularly with respect to, for example, the HPV vaccine in some countries, and getting the word out about, yes, you can survive breast cancer. Come in early when you first feel the lump.
Well, I think we were probably celebrating with you when the elimination commitment went through the World Health Organization for cervical cancer. But being Breast Cancer Awareness Month, I mean, what's your feeling about advances over the last 10 years and where we are now in terms of innovation to address breast cancer? Because we know that in developed countries, we've made remarkable steps in the last 20 years in terms of survival rates, but we're still struggling in lower middle income countries. So where do you see the innovation in the future to address that challenge?
Well, within the treatment arena, you are absolutely right. We have now defined breast cancer as not being just one cancer, but multiple subsets. With all of our genomic profiling, molecular analysis, we can subset breast cancer into many, many different subsets that all respond to therapies differently, should be treated differently, have different risks of recurrence. And as you point out, that multi-gene panel testing, an early stage that tells us a whole bunch of people don't need chemo anymore. And the genomic profiling in the metastatic setting that can pick out mutations and drivers and things that drive therapy, that's just not available in much of the world. As we use it, it will get less expensive. We will figure out how to do this, but that has to be a very high priority, because in breast cancer right now, we cannot have one pathway, one guideline that says, here's how you treat it. And then there are the drugs that go along with those findings in the genomic profiling. HER2 positive breast cancer, for example, when I was a fellow, I studied it in the lab, and it was a horrible outcome if you have HER2 positive disease. Look at our outcomes now. If you can, one, get HER2 testing and even know that you have a HER2 tumor, but two, if you can get access to all these treatments. We have 7 or 8 FDA approved treatments for HER2 positive breast cancer now, and many of them, most of them, are not available in the rest of the world. So we've had innovation, we've had technologic advances, we've had a better understanding of cancer that's leading to better elimination of the cancer, better treatment, more cures. And we just need to figure out how to get it to all patients.
Yeah, I think you're absolutely right. One of the challenges that UIC perceives is that a lot of the knowledge is there to avoid, detect and treat cancers early, but the challenge we have is that's not available around the world, and it goes on education, et cetera, et cetera. I know that the We Can initiative that you kicked off, how successful has that been? What do you think have been the achievements of that movement so far?
We started in Eastern Europe, Central Asia, because I was involved in the Ukraine Breast Cancer Assistance Project, funded by USAID and run by PATH. There we came together every 2 years, and the networking that I saw across what started as the countries of the former Soviet Union, then we added on other Eastern European countries, to know that they didn't need to compare themselves to what was happening in Western Europe or the US, but they could look to each other for ideas. The first time there was a band that showed up in Lithuania with a pink ribbon. It was just an awareness band. It wasn't a mammography band. It was an awareness band that traveled the countryside with a pink ribbon, and women would congregate and learn about their health, essentially. That, when other countries that came to the weekend meetings saw that band and said, you did this with non-governmental money? Teach us how to form an NGO. Teach us about how to do this, and how do you fundraise? And just simple things like that to get the message out. In those countries, many people didn't know a cancer survivor, and they didn't talk about cancer. And I think one of the big successes in Eastern Europe was identifying some cancer survivors who were willing to speak out and say, I had it, I'm alive, this can be you too. Contact us if you have questions or fears. Then we moved to Africa, and boy, you light a fire there and they just run with it. Some of the campaigns they've done, we gave out some very small grants, and what they did with it, like meeting with the women parliamentarians, politicians, to educate them about women's cancers, for example. Low cost, high yield, getting the word out was incredible. So I'm very proud of them, and their voice will continue to be at the table.
Well, I'm sure their voices are very loud during this month, as usual, which is great. I mean, the October month is renowned for pink everywhere you go. So it's certainly raising awareness about breast cancer. What about cervical cancer then, Julie? I mean, what's going on there? What do you think about the elimination story and the commitment? It's a great commitment, and UIC completely supports it. And, one of our team, Julia Terode, worked tirelessly with WHO and others to get that commitment through. It seems like a lot of work to do over the next 20, 30 years, though, and I'm not seeing the same engagement in that we have on the breast cancer side, but maybe it's early days. What are your thoughts?
Well, I see in some regions a lot of engagement. I look at some of what's going on in Africa, that the Africans are really helping lead. And I see the whole come in and get your screening piece of it. And what's going on in Zambia right now, for example, with the social networking of women supporting each other to go get screening. I look at an example I've seen in Kenya about get your HPV vaccine and get the girls out. Of course, COVID put a pause on that right now, and we have some other issues going on in the world. But to see the voice that went out and how the patients came together to try to help with that. I have a lot of enthusiasm for a campaign that really hopes to eliminate a cancer, and we can at least eliminate it as a major cause of death. We might not eliminate every case, but if we can detect it as a precancer or an early cancer and actually prevent it with the vaccine in many patients, then we have a real chance at this. But vaccines take a long time to work, and cervical cancer is, in its earliest stages, very slow growing, which is why you can actually detect it early with the screening and intervene and all. So it's going to take us years, but I am very enthusiastic about this cause, and we just can't let our enthusiasm drop. We have to have this front and center. Cervical cancer and breast cancer are the two most common cancers in the world. And some of the poorest nations have the highest cervical cancer rates. We need to get out there, get the message that, yes, you can do things to improve survival. You can do things in cervical cancer to prevent the disease. And we just can't let the message drop.
I think you said earlier that, even survivors in the old world wouldn't tell people they've had cancer. There was a stigma attached to it and everything else. And I think having a story which says we can eliminate a cancer, we have all the technology, the abilities, the vaccines and everything else to eliminate cancer is a great story for our generation, because that's never happened before. So I agree with you. We've got to keep that enthusiasm up. And as we progress, then hopefully we'll move on to another cancer with the same potential for elimination over time. The World Cancer Leaders Summit is around the corner as we speak, and it's on the issue of innovation and equity. A lot of what you've been talking about there is, just getting the things that we know out there, and even with a very small investment, changing the mindsets and the approach is possible. But do you see any major innovations occurring in the space at the moment, which you are excited about, perhaps in diagnostics, something like that? Can you see things? You mentioned getting cheaper and more available, but any game changes on the horizon for you?
Well, there are studies looking at using some equipment that's already available, they're already trained to use in Africa, for example, that we're using for TB already, HIV, and converting it to being able to take some cancer cells and, for example, look at estrogen receptor, progesterone receptor, HER2. So that's, in a sense, a reverse innovation. We do this complicated immunohistochemistry. It takes a lot of skill, the manpower, the reagents, which aren't available always. If we can convert this to something that laboratories already have that doesn't require quite the skill level, the expertise, the training, we're going to move this very far. And we're doing some studies of that in Uganda. Others are doing it around the world. So I think that's an example of don't get it more complicated, take it back, and look at what's already out there and how can we convert it. That's diagnostics. In screening, a big barrier to cervical cancer screening is we don't like pelvic exams. That's a barrier for a lot of people. And yet there's some good research coming out about Hpv Self Swaps. And so if a woman could do her own self swap, and if we can afford to switch to HPV testing, and then you don't need a pelvic or further exam if you're HPV negative, just think we're breaking down one barrier with something that's very simple. So I think we need to shake up what we're currently doing and look and see, why do we need to do it in such a complicated, in the case of pelvic exam, uncomfortable way? Aren't there ways that we could do things that are simpler? In the case of genomics and some of the other diagnostics, the more that you do it, the more labs involved, the cheaper it gets, the simpler it gets. We understand the technology. Think about BRCA1 and 2 testing, for example, and how originally when it came on the market, it cost thousands and thousands of dollars. Now we've got commercial entities where you can do it for about $100, and probably we can get that way down eventually. And that's what we need to be able to do to get this out to the whole world and save a whole lot more lives.
Well, Julie, thank you very much for that inspirational view of the potential for technology, innovation, and commitment. I don't think anyone will be surprised to know how impactful you are personally, given your enthusiasm and everything that you've done. And we certainly applaud you taking on the role at Chief Medical Officer of Asco. It means that we know that Asco and you will be committed to other parts of the world and not just the US. So from the UIC community, thank you very much for everything you do. And thank you very much for this conversation. It's been absolutely fascinating. So thank you very much.
Thanks, Cary. I'm sorry we can't all be together in Boston for this Cancer Leaders Summit, but we'll see you again somewhere in the world soon.
Of course. See you soon. Bye-bye.